Excellent. So thank you for coming. This is kind of our prevention grand rounds for the year. It's going to be myself and Dr. Martignoni, who's our prevention fellow, presenting this morning. So I'm going to spend 20 minutes or so on a lipid update, and then he's going to spend about 20 minutes on his work he's been doing in lipoprotein A here at the foundation, and just kind of in the broader context of how we should be using lipoprotein A clinically. So I have no disclosures in relation to this talk, and we're going to kind of split this up into two parts. Relatively briefly, go through the current approach to lipid-lowering therapy in the US, and then spend some time looking at future directions as well. I've said this in a lot of talks before. It's really important to understand that the relationship between LDL cholesterol and cardiovascular risk is linear. As your cholesterol goes down, your risk goes down, and as it keeps going down, your risk goes down. And we've had a really hard time finding that bottom threshold. As far as we can tell, an ideal LDL is probably 30 to 50. And we used to say it was 100, we used to say it was 70, it just keeps getting lower and lower. A perfect LDL is probably 30 to 50, and so no matter where you are on that linear spectrum, if your LDL goes down, your risk goes down. And that's exactly what we've seen in the statin trials. As our statins have gotten more efficient, as they've gotten more potent, as people's LDLs have gone down further, their risk has gone down further. And so the more aggressively you treat somebody's LDL, the more you lower the risk. But when we talk to patients about taking a statin, we rarely hear, boy, I'm just not sure if that's going to work. Instead, we hear, I'm concerned about safety. I don't want any side effects, which is understandable. That should be our goal as well. And so recently, we have some data looking at that. So the cholesterol treatment trialists have all the randomized data for statin therapy. So they have the individual level data. So this is the best kind of science when you're looking at these randomized trials. And they simply published recently looking at the safety profile, looking at musculoskeletal side effects on statin therapy for all the randomized trials that we have. So this is a huge study, simply looking at one outcome of safety in terms of musculoskeletal side effects. What they found is that for any muscle pain or weakness, in 123,000 patients, so again, this is as much data as we have for pretty much any medication on the planet, the rate of actual reaction to the statin compared to placebo was about 0.5% higher. So it was basically a 1 in 200 chance of actually reacting to the statin compared to a placebo medication. So not zero by any means, but real very, very low risk chance of reacting to the statin, when observationally we see about 25% of people, about 1 in 4, have a concern about reacting to their statin. In reality, by the trial data, it's closer to 1 in 200. And if you look at the more intensive versus less intensive, I think this is informative. The people on high-intensity statins compared to low-intensity statins. So some of the trials were not statin versus placebo. They were a low-intensity statin versus a high-intensity statin. And in those trials, the rate of reaction was a little bit higher on the high-intensity statin. It was a 1.2%, so about 1 in 70. And so this has been the theme that's been coming out of the literature in the last few years, is that statins are very, very safe, but for the high-intensity statins, there definitely is some risk. People are more likely to react to the highest dose of a statin than they are to the low-dose statins. So those do come with some risk. And also importantly, if we look at the timing of reactions, if they split it up into early and late, this is really important here. For the reactions within the first year, there's a definite increase here of basically a risk of about 1 in 100. So about a 1% chance of reacting to the statin in that first year with serious musculoskeletal side effects. If you go after year 1, which some of these studies are out to 7, 8 years, there's really no increase in risk whatsoever. It's a 0% chance. And so if this is going to happen, it should happen early on. And I think this is important clinically because we have a lot of patients that come in, they've been on a statin for 4 years, and all of a sudden their knee started hurting. They say, boy, I'm worried that this statin is now causing some knee issues, or my shoulder pain, or my backache. We can say with really good confidence, if you've been on it for 6 months or more, the odds of reacting to it are almost zero. We shouldn't really see any late statin reactions based on the data that we have. And so now some of the recent research is focused on, well, we have all these people that are reacting to statins. It doesn't seem to be the statin by the trial data. How do we figure that out? How do we go about testing which people are reacting to statins and which people are not? And if it's real or not. And so this is the Samson trial. This was published a couple years ago. The original trial was in New England Journal just as a letter, but then they published kind of their more detailed data in JACC. And this is a uniquely designed study where they took people with statin intolerance and they put them in a trial for a year. And so for 4 months, they were on a statin, atorvastatin, at 20 milligrams daily. For another 4 months, they were on a placebo pill that looked just like the atorvastatin. And for 4 months, they were on no pill. And so every month, they switched on what they were on for that month. And they kept track of a symptom score, basically, how well they were feeling on and off the medication. And what they found is that when people were taking no treatment, their symptom score here in the gray bar was an 8, which less than 10 is generally people are feeling good. They're feeling generally well when they're less than 10. The minute they started taking a pill, it did not matter if it was the statin or the placebo, they felt twice as worse. And so their symptom score went up to a 15 on the placebo and to a 16 on the statin. And really this fits in the context of what we kind of understand from the science, is that the majority of people that have reactions to a statin, we have pretty good science that it's not the statin. It's the concept of taking the statin. It's this nocebo effect. It's when you go to the medicine cabinet in the morning, you get out a supplement for your health, people tend to feel better. If you got a drug that's associated with illness and toxicity, people tend to feel worse. And yet we see this slight increase of the red bar here compared to the blue, because in a few people it actually is the statin. And that's what makes this so hard, is that when somebody says, I think I might be reacting to my statin, there's a chance they're right, and we don't want to do any harm, and so we have to stop the medication. But yet we know in the majority of those situations, it's not the statin. And so one of the things that we did recently here is try and take this concept of that trial that I showed you, that Samson trial, a step further. And so this is our Decipher trial, which was funded by the foundation. We ran this over the past few years here. And so this was determining statin intolerance for rosuvastatin. That was Decipher. And what we did is we took people who had been intolerant of 2 prior statins. So they had taken a couple statins and had reactions both times. And this was primary or secondary prevention, so it's kind of all comers. And they could be on other lipid-lowering therapy. So maybe they were on Repatha or they were on Zetia and doing fine. And we double-blinded them in a N of 1 trial, it's called, meaning they're both the intervention and they're the placebo group. So the patient gets a month of statin therapy and a month of placebo and a month of statin therapy back and forth, except they don't know which order it's in, and I don't know which order it's in. And so it was a 6-month study. So they had 3 4-week courses of placebo. So 3 of the months they were on a statin. 3 months they were on placebo. 2 4-week courses of rosuvastatin at 20 milligrams, so a decent dose. And again, they don't know which order it's in, and each month they would take a week off in between. So that would get to 6 months total. And if they were reacting to whatever they were taking, they should stop it. So they stop it, wait a week, and start the next packet. And so we had about 24 people go through this study. And what we found is that the mean pain score, whether you were on a statin or on a placebo, was exactly the same. So we had 129 weeks of rosuvastatin compared to 176 weeks of placebo, and the pain score on average was exactly the same. Their overall health actually trended towards being healthier when they were taking the statin. And this was a p-value of 0.02. So I don't think that's real. I don't think you feel better on a statin. But the concept that you'd feel worse sure doesn't seem to be the case based on the randomized data. And then the whole point of the study was to say, can we take this a step further, and can we bring this data to the patient and have them use it to make a decision about taking a statin? And so what we had happen was that 24 people consented for the trial, so just a small little pilot study. 5 of them withdrew consent during the study, saying, I don't want to do this trial anymore, it's too stressful, which is understandable. You know, trying to assess these symptoms all the time when you think you might be reacting to a medication definitely is stressful. In those 5 that withdrew, none of them had any actual evidence of true statin intolerance. 1 was lost to follow-up, and the other 18 completed the full 6-month protocol. Of those 18, we had 1 where it sure seemed like when they're on the statin, week 2 and week 3, their symptoms started to go up, and on the placebo, it didn't happen. And so 1 patient, it seemed like it was truly statin intolerant. 13 of them had really no data, where the numbers were just kind of all over the place. There was no correlation with being on the statin and any of their symptoms. And then 4 had data which we couldn't quite know how to interpret. They had 1 month that was bad and 1 month that was good, and it was kind of hard to tell what was what. And so we took that data to the patient and showed it to him and said, okay, here's your own data. Are you now willing to try 3 months of unblinded statin therapy? So now let's try this without the placebo design and to see if you can tolerate a statin. And of the 14 that agreed to do that, so really we had 18 that finished the protocol, 14 said, yeah, you know, based on what I'm seeing here, I think I'm willing to try the statin. Of those 14, 12 tolerated it for a full 3 months. And so we were able to get 75% of these people on a statin and tolerating it fine once they saw their own data. You know, and I think you can tell a patient about a 120,000 patient trial, right, with all this data, and they're like, well, that's fine, but that's not me. And so when you show them their own data saying this is how you felt on the placebo versus this is how you felt on the statin, I think it's pretty compelling, it's pretty convincing. So this potentially can be a method to facilitate statin tolerance. So we can take people who are intolerant to a medication, have them go through the protocol, and then get them on the medication. And obviously we have other options for lipid-lowering therapy, but still the foundation of lipid-lowering therapy for prevention is statin therapy. And so potentially that could be of some use. So we recently published this in JACC Advances as a research letter, and so now we're moving forward with a multi-center trial. So we have several other institutions around the country that are interested in participating, and so we'll be starting that relatively soon, and I think it's going to be interesting to see what we find. So obviously that's probably not going to be our bread and butter approach to statin intolerance, because that's a little bit complicated to do and patients aren't super excited about participating in those kind of trials sometimes. Another alternative is simply not to use statin therapy or to use less statin therapy. And so we have the Improve It trial, which was Zetia, a Zetia study published in 2014. And again, this is a large, well-done randomized trial, relatively straightforward design of a statin and a placebo in people post-acute coronary syndrome versus a statin and ezetimibe, 10 milligrams daily. And you can see on the statin alone, people got down to an LDL of just under 70. You think about our patients that come to clinic and their LDL's in the 60s, you say, you're doing great. No changes needed here. That's right where we want to see it. And yet on the Zetia with the statin, they got down to an LDL of about 53. So about a 15-point reduction, so not a huge reduction. And yet over time, that was enough to result in a significant reduction in heart attack and stroke and cardiovascular events. And so even the little bit of LDL lowering that Zetia provided seemed to provide some benefit. And then more recently, they actually published kind of a secondary analysis looking at, well, can we do a better job of getting Zetia to the right people? And so this is that same trial analyzed in a little different way. They basically took those outcomes and they analyzed them by the patient's baseline TIMI risk score. So that's this score over here on the side. And so these are all things that make patients higher risk. And so you get 1 point for each of these. And when they broke down the study, half the trial, so there was about a 17,000 patient trial, half the trial had a score of 0 or 1. And that's this first group right here. And in that group, there was really no benefit to taking the Zetia. For people that were low risk, even if their LDL was a little bit high, taking the Zetia didn't have much benefit because they're low risk. It's hard to prevent things that weren't going to happen in the first place. And so the Zetia group really didn't benefit that much. Conversely, if you look at this high risk group here, 3 or more, there's a 6% absolute risk reduction with Zetia, which is a huge number in terms of absolute risk reduction for lipid-lowering therapy trials. And so almost all the benefit in that trial was just in that 25% of people that were high risk. So again, the more we can allocate these things to the right people, the better we're going to do, the more we're going to reduce cardiovascular events. And so in addition to Zetia, we have the PCSK9 inhibitor. So I showed you the LDL reduction for Zetia, which in the trial was from 70 down to about 55. Here in the placebo, or the PCSK9 trials, in the placebo group, they're at about an LDL of 90 and they got down to 30. So this is much more substantial LDL reduction. This reduces LDL a lot more efficiently than what Zetia does. And with that, in a short-term trial, we saw less cardiovascular events. Again, fits very much with that linear relationship. The more we can drive LDL down, the better people do. And so some of the critiques of this trial is that it was pretty short-term. It'd be nice to see some longer-term data. And so recently, the Fourier trial published longer-term data, their extension of the study. So this is called Fourier-Olay. And so original trial was a 2-year study, placebo versus PCSK9. This study was the 5-year data, and at year 2, when they became unblinded, the PCSK9 was offered to everyone. And so anyone in the trial that wanted to keep in the trial could stay on it and be on the actual PCSK9. There was no more placebo group. And so we see here the LDL in the placebo group dropped to the LDL of the intervention group. And so this is not 5 years of PCSK9 versus 5 years of placebo. This is 5 years versus 3 years. This is looking at starting the PCSK9 earlier in the course of disease. And so it's not just a placebo-controlled trial. You're looking at just starting earlier make a difference. And it definitely does. That benefit that was seen in the trial persisted and in fact expanded a little bit. So they had a 15% reduction in cardiovascular events with earlier use of PCSK9 therapy. And so the real theme of this is that the earlier we intervene, the better people do. The longer you lower your LDL, the better people do. And actually they saw a reduction in cardiovascular death in this trial, about 13%. And that's important because for most of the lipid-lowering therapy trials, we haven't seen that. Most of the lipid-lowering therapy trials don't reduce cardiovascular death very well because there's deaths from heart failure and deaths from arrhythmias and deaths from aneurysms, a lot of things that lipid-lowering therapy doesn't affect. And so typically it's been hard to reduce cardiovascular death in these lipid-lowering trials, and yet this one had it over 5 years. And so if you remember any of the trials that we talked about today, this is the one I'd like you to remember because this is kind of where the recent theme has been going in prevention for lipid-lowering therapy. And so this is looking at using combination therapy versus simply high-intensity statin therapy. And so this trial was looking at 10 of rosuvastatin and 10 of Zetia compared to 20 of rosuvastatin. And you think in clinic, that decision between 10 and 20 we take pretty lightly. We just say, oh, either one you want to take is fine. This looked at a high-intensity statin versus combination therapy. And the results were interesting. So the red bar there is the people on combination therapy. So if you take a low-dose statin with Zetia, you're going to lower your LDL more than you are with a high-dose statin. So it's more effective at reducing LDL, the combination is, compared to the high-intensity statin. And if they looked at discontinuation for safety, they're much more likely to stay on the medication if we use the low-dose combination approach. And so the high-intensity statin definitely has more risk of side effects. There's more risk of musculoskeletal side effects. And if you look at that blood glucose change that we've seen, the increase in diabetes in the statin trials, it's mainly at that high-intensity dose. The lower doses don't seem to do that near as much. And so from a safety standpoint, it's a lot better to have a patient on 10 of rosuvastatin than it is on 40. And if we use Zetia with it, we're going to have better numbers. And so when they looked at outcomes, it was a non-inferiority trial. The red line is the combination group. It was definitely non-inferior, and there was a hint that it might be even better, that because you're lowering LDL more, you're getting more risk reduction. And so if we have an intervention that's better and safer, to me that seems kind of like a no-brainer. So the real shift has been we should be using more and more combination low-dose statin therapy here moving forward. I think for secondary prevention, for our patients in the hospital with a heart attack or a stent, that probably should be our go-to. We should be using 10 of rosuvastatin and 10 of ezetimibe. That's going to work the best, and it's probably going to be the safest. So this is our current approach to lipid-lowering therapy, and this is pretty simplistic, but I think it's pretty accurate. Based on somebody's cardiovascular risk, we should have a really low threshold to put them on 10 milligrams of rosuvastatin. If they have a risk factor, if they have a family history, if they have concern about the risk, if they have a high calcium score, getting on that low-dose statin is a really good idea. It's going to reduce their risk, and it seems to be quite safe. We should have a relatively equally low threshold to add ezetimibe to it. Again, it's cheap, it's effective, it's very safe, it doesn't really come with any risk of side effects, and so I have a pretty low threshold to add that ezetimibe to that low-dose statin. And then we have the PCSK9s for our people at higher risk who we don't get to our LDL with our initial approach. And so they're a path on the probably we save for when we need them, and they're very effective, and insurance will approve them most often right now. And so to me, this is kind of the modern approach, and the theme has been, in the last decade or so, we want your LDL for as low as possible, for as long as possible. So the earlier we can treat it, the better people are going to do. Now, thankfully, we do have some other things coming down the pipeline here, so we have some other options that can help kind of aid this approach. And so now we have a medication called inclisiran. So inclisiran is like Repatha, except it works at a more molecular level to inhibit PCSK9, and it has a durable effect. So you do a dose, and then a dose at 3 months, and then from there on, it's every 6 months. So it's an every 6-month injection. We're working on kind of transitioning it to be able to give it in clinic, so a relatively safe way to give it, an easy way to give it, and it's quite effective. It lowers LDL again by about 50%. That's similar to what we see with Repatha or Praluent. So having this option available for some of our patients that travel a lot or have a hard time with that every 2-week dosing, I think is potentially helpful. We're going to start using this more and more, I think, as we go along. We have bempedoic acid, which is a medication. It's an oral medication. It acts on the same pathway that statins act, for a little bit further upstream compared to a statin. And the unique thing about bempedoic acid is that it's a prodrug. It's not actually an active drug when it's circulating in your system. It doesn't get turned into an active metabolite until it's in your liver. And so potentially that could lead to better safety, where we see less musculoskeletal side effects because the bempedoic acid really shouldn't cause any of those because it's not active until it's in your liver. We have evidence that reduces LDL by about 15%. And so that's similar to Zetia, so a relatively modest reduction. But yet now we have outcomes data supporting that it works as well. And so this is recently published in New England Journal in looking at cardiovascular outcomes in people who are statin intolerant. Again, that's kind of the marketing for this medication. That's who it would be good for. And we see a 23% reduction in heart attack with use of this medication over 5 years. And so again, even small reductions in LDL have the potential to impact cardiovascular rates over time. And then some of you may have participated in our Kevin Graham lecture a couple years ago. This was Dr. Katharizan, who had started a company called Verve Therapeutics, which was looking at genetic editing to reduce LDL. And so now they have their first in-human trials they're publishing. And based on the dose, they now can show that they can effectively reduce LDL by about 50 or 60%, and it's lifelong. So it's a one-time infusion that goes to the liver and edits your PCSK9 gene. Your PCSK9 protein then is defective and doesn't work. It's like a PCSK9 inhibitor, and you're done for the rest of your life. And so they have human trials ongoing. They've been dosed. The safety profiles so far look really good. And so we'll see what the outcomes show, but I wouldn't be surprised in 4 or 5 years if this is an option. They're also working on therapies for lipoprotein A and for another ANGL-PTL3, another one they're looking at, where if we inhibited all 3 of those, your lipids would pretty much be perfect. And so, in our future approach, I think we're going to be adding some inclisiran, the every 6-month injection. We have this bempedoic acid, which is for statin-intolerant patients. We have lipoprotein A, which I didn't touch on because Dr. Martignoni is going to tell us about that. And then potentially some genetic editing, which sounds scary. It sounds kind of frightening. But so far, the safety data look really great. And so, yeah, we'll see where that goes. So I think we'll save questions. Dr. Martignoni will go next, so we can do questions afterwards. So Dr. Martignoni is our prevention fellow this year. He's a fully trained cardiologist and PhD from Brazil. And him and his wife and family came to the U.S. A number of years ago. He's been training in Montana, doing internal medicine, and he's been participating with us in a research fellowship this past year. He's working on several different projects, and he recently was accepted into Texas Tech for cardiology fellowship, so he'll be heading down there this summer. And so he's going to tell you about some of his work he's been doing on lipoprotein A. It's all yours.
Can you guys hear me well? All right. Well, I have no conflict of interest. My objectives are to maybe we can understand a little bit better the role of lipoprotein a and cardiovascular risk assessment, and maybe discuss future treatments. So, little history on this. In the 1960s, it was described, Dr. Carl Berg from Oslo described that there was an antigenic variant of LDL and already described a gene, at least a gene phenotype frequency. And 15 years later, they actually isolated the gene and the protein that he was talking about. It was very similar to plasminogen. And now we kind of formulated, this is everywhere. And anywhere you go, you talk about LPA, you're going to see this little structure here. It is an LDL-like protein. but it is attached to, it's an LDL-like particle attached to this protein called ApoA. Now, as you can see, so ApoA, that looks like plasminogen. Let me see if is there a pointer here? Looks like plasminogen. Homology is very high, 90+%. There is this protease domain that does not have an effect. And then there are these Kringle repeats. These are amino acid sequences that fold itself into like a pretzel-looking protein. And a Kringle is a Danish pastry that looks like a pretzel. So whoever discovered it gets to name it after their own pastries. Plasminogen has a Kringle repeat from 1 to 5. ApoA skips 1, 2, 3, and has then Kringle 5, and then a bunch of repetitions of Kringle 4. This is all important in the end when we're talking about testing for these things and the therapy. So Kringle 4 then repeats itself to 10 different Kringles, but Kringle 2 here, as you can see, is the important one because the variance on the amounts, repetitions of Kringle 2 is what's going to make this protein very difficult to test, and also has an important effect on atherogenesis. So it is considered a risk factor for atherothrombotic disease and even aortic calcification. It is genetically determined. That means, well, it's codominant. You inherit from your mom and your dad, like the ABO system, and there is not much you can do. Lifestyle modifications does not change the LPA, the expression of the protein, but it changes your risk factors overall. And it is on chromosome 6 at the LPA gene. Now, so the prevalence in the world depends on inheritance. In Africa, it's about 30% of the population. And then it traveled through Europe and Asia, where Africans have the highest prevalence of elevated Lp(a), as if we consider over 50 milligrams per deciliter, 125 nanomoles per liter. Then South Asians, then Southeast Asians, and the lowest are in Han Asians and Latin Americans, or actually, I think the term was Hispanics mainly. So in general, at least in America, 20% of the population will have an elevated Lp(a) as a risk factor. Now, how does this work? Well, it is an LDL-like particle, and the LDL that is attached to that protein has higher amounts of oxidized phospholipids. So it carries the LDL-like risks. It increases atherosclerosis. So it induces small muscle cell proliferation and migration. It also it penetrates through the endothelial wall and then activates macrophages and increases inflammation. But the protein itself, the ApoA protein, the plasminogen-like effect, also increases thrombosis and also increases intraluminal inflammation, interleukin-6 increase. But it can penetrate to the interstitial cells of the aortic valve and induce calcification of those cells too, which is different from other lipids. Now, the evidence linking Lp(a) and atherosclerosis has been all over the place. In the beginning, there was a lot of difficulty making that link because of the way we measured Lp(a). 2009 on, the labs kind of agreed on how to measure it, and we were able to make a more distinct link between lipoprotein(a) and multiple types of atherosclerotic disease. So we have long prospective studies, we have meta-analysis, we have Mendelian randomization studies with genome-wide association studies that have proven to link Lp(a) and ASCVD, and also to aortic calcifications. We have Mendelian randomization, even a Fourier trial helped link that too. And ischemic stroke is also a big one. Now, this is our data here. We published a meta-analysis that was just recently published at the European Journal of Preventive Cardiology, the association between lipoprotein A and coronary calcium score and progression. Now, this is very interesting. Well, we know it's a risk, but how much of a risk? We have much more LDL circulating, LDL particles without the ApoA attached to it. So population-wise, LDL carries a much higher risk. But particle per particle, this study, also very recent study, 2024, has shown that lipoprotein a carries 6 times more atherogenicity than one particle of LDL itself. Whether it's due to the protein itself or the increased oxidized phospholipid content, there are many theories and hypotheses, but it does carry higher atherogenic effect. Interesting things about populational studies that we make 1,000 associations with everything. And the higher the Lp(a) levels, the lower the risk of type 2 diabetes. Now, well, so you can say, well, it's protective. And actually, it's not protective at all. But if you do have both, your hazard ratio of having atherosclerosis is 1.9. This study also just recently, it was published on the 18th. It was sent to me just a couple of days ago, so it was quick to read and interpret what they meant. But it's a pool cohort using MESA, Cardia-Jackson, FHS, and ARIC. So pretty large, 20 plus years follow-up, showing that if you compared the lowest quartile of Lp(a) at the highest quartile, you can see an increment. To each quartile, there's an increment in risk. And that risk was stronger in patients with diabetes than in patients without diabetes. Very interesting findings. Now, this is borrowed. So at ACC, I was looking for a more objective answer to give patients when you order Lp(a) and they're like, okay, this is a risk enhancer, so what do I tell them? And I hadn't seen this as incredible as things. It's not new, it's from 2021, but I saw this in ACC this year. Now, this is not a new graph. This is from the Mendelian randomization studies showing that the linear effect, like LDL, the higher the Lp(a), the higher the risk. Well, you dose somebody's we can calculate the overall risk using the pooled cohort. And so we ordered Lp(a) and we're like, all right, what now? It went from 7.5 to what? To 15? What can we say? So they came up with this equation where to every 50 nanomole of increment, you can increase about 11% the risk on the overall pooled cohort risk. So an example is this patient's baseline risk is 10%. He's intermediate. And you dose Lp(a) and it's 250 nanomole per liter. That's a pretty high number. Then, well, you divide that 250 by 50 and you elevate their risk 1.11 because it's to every 50, 11%. And then the new magical number that shows up is when you take into account the patient's Lp(a). So from 10% went to 17.3. In that way, you can help guide making decisions on how aggressive you're going to be on lipid-lowering therapy or other things. This is also not a new graph, but very interesting. So on this side here, you see that we're looking at LDL lowering, and on the right is Lp(a). Now, using genetic association or genetic estimates, Mendelian randomization studies versus observational studies versus looking at what the statins and the PCSK9 studies got us, we can say that if we want to reduce risk by about 22%, you have to reduce LDL by almost 40 milligrams per deciliter. So this is pretty well established. Now, Lp(a), we did genetic, the Mendelian randomization studies, the observational studies, showing that you have to lower it in about 100 milligrams per deciliter to have the same 22% reduction that you would with 40 milligram reduction in LDL. Well, that's great, but nothing right now can reduce 100 milligrams per deciliter, except if you're very high levels, and a PCSK9 might get you there. So that's why you see that the little dotted line here for trial is an estimated, it's a projection, because most of the studies we have are phase 2 and based on genetic estimates. All right, so what can influence, non-genetic influences on Lp(a)? Well, Lp(a) is mainly genetic, cleared by the kidneys. So if you have kidney disease, you will kind of accumulate it in your bloodstream. So nephrotic syndrome can increase it 3 to 5 times. CKD increases, makes it larger too. Liver transplants, you reflect the donors, new Lpa. That's rare. Thyroid disease, though, hypothyroidism increases Lp(a) levels by a little bit, but still increases. And menopause has minimal effect, but post-hormone replacement therapy decreases it by 25%. Statins, variable. Some studies show that increase about 10%, and PCSK9 can decrease it up to 30% if they're very high baseline. So what do we do? So you got the patient, he comes in, you calculate the risk, and you know the statins will elevate Lp(a). So what do we tell him? Well, like every single thing in preventive cardiology, lifestyle modifications is king. You will, with diet, exercise, and having a healthy lifestyle, this study is from the Norfolk EPIC study showing that in patients with low Lp(a) or below median and above median, you can still have, in all groups, have a reduction in risk on unhealthy lifestyle to healthy lifestyle. And although in those with higher Lp(a) have a little bit higher risk, but still better than patients with normal Lp(a) and unhealthy lifestyle. So lifestyle is king. Now, there's a question about PCSK9. We can reduce it up to 30% if your Lp(a) levels are very high, but it is not yet out there. There's still studies going on. We still have to determine it. There are questions about niacin. Niacin reduces Lp(a) in about 30%, but again, so far, nothing telling us that this is going to reduce mortality. Aspirin's a big question mark. The World Health Initiative and a few post hoc analysis of previous trials showing that the risk of bleeding in those with elevated Lp(a) is not the same, is less than maybe due to the prothrombotic effect of Lp(a). So less risk of bleeding and better preventive. So that's a big question, what to do with aspirin high Lpa. The only FDA-approved treatment is Lpa apheresis, which is cumbersome but effective, and it's on those cases that are very, very elevated. And then we're exploring the targeted therapies from phase 3 trials. Before we go there, let me just kind of give you guys a little update on this is a 4-year study showing that Lp(a) on the left side here is showing that only on a median, lower than median versus higher than median. And then they kind of put it on less than 120 nanomole per liter versus over 120, which is considered high, showing that Lp(a), evolocumab, did decrease risk compared to placebo in patients with low Lp(a) and high Lp(a). But Lp(a) did have an effect in both groups. It increased risk in both groups. Therefore, it's not only a risk enhancer, but rather it can be considered a mediator here on all groups, not only an enhancer. And this shows, like that dotted line we saw, this is a trial showing that the amount of Lp(a) to decrease about 20% in risk in 4-year trial was about 60 nanomole per liter. The other graph was in milligram per deciliter. This is nanomole per liter. There's a whole new hour discussion on that. We'll try to avoid it today. And now these are the targeted, Lp(a) targeted outcome trial. Now, we have more than 2 drugs being tried. I'll just speak about 2 because it kind of has a general, none of the results are out yet anyways. So the antisense oligonucleotide ASOs, so pelacarsen, and the trials LPA Horizon, and then there's small interfering RNA, which is opisiran, and the Ocean A trial. Now, what did they do? So, antisense oligonucleotide, you inject into the person this antisense, it's an RNA strand that will, after the transcription of the messenger RNA, once that strand connects, it induces the RNAs to go and break down that messenger RNA. So you have no protein expression. You do not produce a protein. And these are kind of short-lived, so they're playing around with other carbohydrates and sugars to attach to it so it lasts a bit longer, and they were very effective at it. In small interfering RNA, it's a bit different. It's longer acting. You inject this guide strand that interacts with the silencing complex, and that kind of gets stuck in there, and the cycle repeats itself, degrading RNA, mRNA for a prolonged period of time. So with one injection, it lasts a lot longer. So these are phase 2 trials of ASOs showing that you can reduce Lp(a) levels by 80% with 20 milligrams every week injections with minimal side effects, mainly injection site reactions. And they saw that over time, this has maintained the 80%, and you can have about 98% of patients having an Lp(a) less than 50 milligrams per deciliter. So this is very effective. Phase 2 trials are great. Now we're going on phase 3. And these are the small interfering RNA trial, phase 2 results showing that with injections of every 24 weeks, so very long-acting medications, you can have results, mean percent changes, prolonged mean percent changes of about 100% decrease in baseline Lp(a). So these are these trials are going on throughout the world. Even here, we have patients being selected here, and they're a little bit different from each other. The Horizon, LPA Horizon is testing a little more patients in Ocean A and for a little longer, but the LPA levels aren't as high as Ocean A. They're going for higher levels and a little shorter. So who to test? Now, when you are in clinic, especially primary care, and you have that very limited time to talk about osteoporosis and pap smears, and you have to decide if you're going to go into the rabbit hole of checking further and what to tell the patient. And then you have to remember, well, if there is a family, if there's a family history of below 50, and if you had a high cholesterol, but then you did not have, you're not going to remember. So one after the other, the societies are coming down on to this, which I think is going to be very helpful. Once in a lifetime, over 18 years of age, check it once. Since it's stable, you don't check it when the patient is sick, but you check it, when it's stable in the outpatient setting, and you will have an idea of what the genetic outcomes there is going to be for Lp(a). So universal screening. This just came out April 2nd. NLA had a long, lengthy, do this, do that, and you have to think about all this stuff. But now it's pretty clear. Over 18, check it. We're good. All right, so now what do we have here? So this is a study we've been doing. So we have data from 2004 to 2023, so roughly 20 years, 419,000 patients, and 1.8% were tested for Lp(a). Out of that 419,000 patients from 40 to 79 years of age, so we did not check the 18-year-olds, Median age 61, 52% female, 90% white, 61% dyslipidemic, and 11% with ASCVD. Now, that is the overall population of 40 to 79. Of those, 1.8% had it checked, 1.4% primary prevention setting, and 4.9% in those with known established ASCVD. Now, this is interesting. So we had two measures. We did a change in the labs. So when we measured in milligrams per the mass concentration in blood, our median was 20 in those without ASCVD, and the median was 27 in those with. Nanomole per liter was also, this is considered very high levels of Lp(a). So 27% of our population tested had elevated Lp(a) versus 36. Whereas when we're looking at those studies, the pool cohort studies showed it was less than 20%. And we think the world population, well, at least in America, is about 20%. So this is showing the proportion of elevated Lp(a), and something happened here in 2013 to 2014 that things changed. Well, we had a way to measure it. We changed the way to measure it, and something happened again over here that changed again. And we went to the third different type of assay that we're using. Now we're measuring in particle number, nanomole per liter. So this is the proportion of elevated in percentages. Now this is the type of people we're testing. In 2004, the majority of people tested were those with known established ASCVD. And as time went by, something changed that now we're going to a more primary prevention, low borderline risk patients are being tested more than patients with ASCVD. So our outcomes are 30% of patients had elevated Lp(a) in our cohort. 59% of them, when they checked again, varied over 20%. And we have very stable levels throughout the literature. So something's up. We gotta figure out why there's so much variance. It could be unaccounted for, well, we checked it and very high risk, started a PCSK9 inhibitor, which is known to decrease 20%, or they started on statins or they stopped statins. So that's something to look at. Or it could have been also, we measured with nephelometry in 2004, and then we measured it again in 2010 using immunoturbimetric studies. And there is an association of lipid-lowering therapy and high Lp(a). Now, 7,618 patients were using lipid-lowering therapy, and we can see in every single ASCVD group from low, borderline, intermediate, high, and established ASCVD, Lp(a) was associated with higher prescription of lipid-lowering therapy. Whether this is the cause or the effect, we don't know. This is cross-sectional in nature. All right, just to end, so my Lp(a) talk is done here. Just to end, another result that we have from our studies here is showing that this is a STEMI study showing the patients that showed up with STEMI to ER, and we have data from also 2003 all the way to here. The first decade of this study was already published by Dr. Miedema, and now we're looking at the second decade of this study showing patients that showed up with STEMI in the ER. Were there any major changes in risk factors 10 years ago to now? And were there any major changes in preventive medications from 10 years ago to now? And difficult to see, I'm so sorry. This graph here is showing risk factors, and this graph here is showing preventive medications. Risk factor prevalence did not change much except for a slight increase in type 2 diabetes compared to 10 years ago. And the dotted lines here are secondary prevention, and the lines are primary prevention. We saw that there was a slight decrease in aspirin use from 10 years ago to now in secondary prevention. Probably some confusion from the 2018 trials in aspirin, misinterpreted there were primary prevention aspirins versus this is secondary prevention. That's my conclusion, no one else's. And, and we saw that there was a mild decrease in aspirin here, but there was an increase in ACE, ARB, and a little bit higher beta blocker use, but very mild. So we can say that in 10 years, there hasn't been much change in preventive medications. There hasn't been much change in traditional CVD risk, except for a slight increase in diabetes. And we have to reach people again a little bit earlier. 70% of the patients that showed up with a STEMI did not have established clinical ASCVDs, so they're unaware of what was going on before they had the STEMI. All right.
We're happy to take any questions. John.
Yes. Thank you so much, both of you gentlemen, for the fantastic presentations. We have a couple virtual questions thus far. The first comes from Dr. Burke. I think this came through during Dr. Miedema, your portion, but I could be wrong. The question is, when and how do you treat triglycerides?
Yeah, that's been a little bit of a winding road. You know, for people that have genetically high triglycerides, like into the thousands, they don't seem to increase cardiovascular risk. They seem to be too big to actually penetrate the vessel wall, and so they're not atherogenic. And so for the longest time, we were kind of ignoring triglycerides for the most part. Now we have pretty good evidence that triglyceride-rich lipoproteins can be atherogenic, especially in the context of metabolic syndrome. And so, you know, Zetia and rosuvastatin lower triglycerides really well. And so that would be the main treatment for LDL is the same treatment for triglycerides. We know that the new GLP-1s for weight loss actually reduce triglycerides really well. We do have a couple new medications that are being developed that can lower triglycerides substantially. Evkeeza would be one of them, and so we've got a few patients we're using that in, and so we have plenty of options. Quite often we can treat it pretty effectively.
Thank you. There's an additional question comes from Dr. Lesser. I believe this is for Dr. Martignoni. The question is inclisiran available now in the prevention clinic? And I suppose this could be for both of you. And then the follow-up question is it or any other new medication subsidized?
Yeah, I'll take that. So there are occasionally we can get programs through the pharmaceutical companies or through other companies to subsidize them. We can get them approved in certain situations. Inclisiran has been interesting because it still doesn't have an outcomes trial, and so we're kind of waiting on that. But yet we have really effective LDL lowering. It seems to be quite safe. The every 6-month dosing is potentially a real advantage, and so initially how we distribute medication was a pretty big issue, and so we were going through infusion centers. Now that's kind of been shut down, and now we're going to probably be giving it in the clinical setting, or they can just ship it to the clinic and give it to the patient right in clinic. A nurse can do a sub-Q injection. And so yeah, it's pretty variable from patient to patient. I'm kind of vague on purpose because everyone seems to be different insurance-wise. But we've definitely had some insurance companies that will approve inclisiran but won't approve Repatha. And so it's pretty variable from person to person. Yeah, Ivan?
Yeah, thanks. Really great talk, guys. One of the things I'm interested in, I thought it was really remarkable when they did those 3 reversal trials that there was all this reduction in plaque area by IVUS.
Yeah.
And now, I missed part of your talk at the beginning, but now it seems like the theme is we can back off on the intensity of the statin. I think specifically rosuvastatin you were referring to, and add Zetia get maybe even a better effect. Outcomes seem to be similar, I guess what you're saying. And so do you think that in these patients you may be seeing the same reversal, if that's even clinically important other than events?
Right. So it's a good question. So we had a lot of trials looking at high intensity statin compared to low intensity statin, and the high intensity statin was better in terms of plaque volume reduction, in terms of outcome reduction, right? It seemed like it was definitely better. And that seemed to be largely driven by LDL lowering. Where the LDL is what was most predictive of those things. And so if we can get to, you get about 80% of the benefit of 10 of rosuvastatin compared to 40. And if you add Zetia to that, you're going to go past that 40 of rosuvastatin in terms of LDL lowering. And so you would assume the plaque reduction, the plaque volume reduction should be better, because it really should just be based on how much we lower LDL.
And you translate that to the atorvastatins and other
statins? The data for atorvastatin and rosuvastatin are pretty similar. Rosuvastatin maybe just slightly better, and then that safety debate definitely is better for that low dose rosuvastatin. 40 and 80 of atorva have those similar kind of increase in blood sugars and the higher musculoskeletal side effects, and so again, we're talking about high risk. We're talking about a 1% risk, right? So it's not a high risk thing, but in terms of statin safety and what our patients want, they seem to be very excited about the idea of a low-dose approach compared to taking the high dose.
This is sort of a follow-up question, and congratulations for all the publications you guys have done on this. What is your view on ultra-low LDL in this world? And let's say you had a STEMI.
Yeah.
And what would you want your LDL to be? And is there, when you look at the really low LDL patients, what do you see in terms of outcome?
Yeah. So, there's a whole book called The Cholesterol Myth that it's all about how doctors are chasing cholesterol and we shouldn't be, and that if we lower our cholesterol too much, our body's going to fall apart and our brains are going to turn to mush and it's going to be really bad outcomes. And a lot of that comes from a study out of Japan where the people with the lowest LDL live the least amount of time. And that you can replicate that pretty easily. In older populations, LDL is a marker of frailty. As you get end-stage liver disease or end-stage kidney disease or malignancy, LDL goes down pretty substantially. And so if you injected them full of LDL, they wouldn't live longer. It's just a marker. And so, the reason, one of the ways PCSK9 inhibitors were found is they found a couple people who had genetic edits in PCSK9 that made it defective. And so those families have LDLs of like 5 to 10. They basically have no LDL in their system, and they seem to live long, and they live well, and they don't have any dementia, and they definitely don't have any heart disease. A newborn baby has an LDL of 30, and seems to be pretty happy. And they built their whole brain on an LDL 30. It seems like we probably maintain ours on an LDL 30. And so I think most preventive people would agree that 30 to 50 is probably ideal. And so I think less than 50 is what the European guidelines have gone to. It's pretty reasonable. But again, how you get there matters. We don't want to spend too much. And so I think, going to that rosuvastatin and ezetimibe pretty quickly is a good idea. If you get to 55 on that, I don't think I would add a PCSK9 inhibitor, And so the LDL goals always get a little bit tricky in that setting. It's more about what you're used to treat it as well. And so, yeah, I think most preventive experts would say 30 to 50. Also importantly, when you get to, the LDL is estimated based on that equation, right? And that equation really breaks down when you get down to less than 40. And so a 5 could be a 20, could be it's pretty inaccurate. And so that's why less than 50 is probably just a better statement.
Thank you.
Yeah.
Just to wind back to primary prevention, and maybe you did allude to this. We have a lot of patients we see who just get a calcium score because their second cousin collapsed or something, And then they come in, they're in their 40s or maybe early 50s, and you have to decide whether, they have, a calcium score around 300. You have to decide whether you put these guys on lifelong statin or not, or a combination of the SADIA thing. When you look at primary prevention by itself compared to the impact of therapy compared to secondary prevention, do we see the same impact in these populations? Because the calcium score population is, I think, more heterogeneous as far as risk. They're not maybe as high risk as you might think.
Yeah, it's a good question. It would be really nice if 20 years ago they had done a randomized trial for calcium scores. That would have been really nice. We have a small one, but we don't really have any big data. And so there's a lot of estimations and speculation. By the data, for people that have a calcium score of 300 or more, they have a risk equivalent to secondary prevention. So that should be considered the same as a secondary prevention patient. Whether or not the interventions work as well in that group, we don't quite know for sure. Now, by the data, based on event rates with people's scores of 0, it almost is impossible that in the primary prevention trials, the benefit was somehow different by calcium score. It has to be in the people that have high calcium scores, because the people with 0 don't have any events. And so there's no, just by a number standpoint, the people that have elevated scores has to be where the benefit is. And so is it the same as secondary prevention? Probably not, maybe a little bit less. But for rosuvastatin, we've got trials up to 30 years now. And in 30 years, it doesn't seem to cause any harm. And so we were talking about at ACC, they're looking at a trial of looking at rosuvastatin as an over-the-counter option for low-dose rosuvastatin. And so I think as we get more patient empowerment with, having it in the Costco aisle next to the other supplements, I think that'll be better uptake than when we get prescribed by your doctor. And so for a high calcium score in your 40s, I definitely would have somebody take low-dose rosuvastatin. All right, thank you. Have a good day.